Ma'am, we are live now. Yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, AMOGS Emergency Obstetrics Committee with Aurangabad, Beed, Nanded, and IMA Maharashtra State. And today's episode is episode 34. So it's my privilege to introduce the coordinator of this webinar, Dr. Monica Umbardhan ma'am. Ma'am is the consultant.
Anxiety, that should be fine. I think everybody else is waiting.
Yes.
So let us go. Thank you for introducing the webinar. My co-coordinator is Dr. Madan Kamble, sir. He's the chairperson of the Sexual Medicine Committee and the zonal coordinator for AMOGS. And we welcome you to the 34th episode of the Emergency Obstetric Committee webinar of AMOGS, which is chaired by Dr. Sneha Bhuyar, madam. This webinar is with the Aurangabad, Beed and Nanded societies. And today we have respected Dr. Uday Thanawala, sir, who will be speaking on thromboprophylaxis in pregnancy, followed by a panel discussion on hematological disorders in pregnancy. So we wait for an excellent academic session. Before we start our program, let us take blessings from Lord Almighty. Saiti, can we have the inauguration slide, please?
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
Thank you, Sahiti. It is my proud privilege to introduce our convener for today, Dr. Sneha Bhuyar, madam. She is currently the chairperson of the Emergency Obstetric Committee. She has been the past chairperson of Foxy Breast Committee. Madam has many firsts to her credits, including she's the first national faculty from Yavatmal, the first fellow of ICOG, the first Foxy chairperson from Yavatmal. He has also received the National Individual Awards by Foxy like Unsung Hero, the SN Malhotra Award, and the Dursha Community Service Award. She has been the first to receive the State Award for Healthcare by the Government of Maharashtra. We welcome you, ma'am, to welcome this August gathering.
Thank you so much, Monica. A very good evening to all of you. At the outset, I would like to welcome all of you and especially the warm welcome to respected President AMOGS, Dr. Kiran Kurtakoti and Dr. Santosh Kadam, President of IMA Maharashtra, Dr. Rajendra Singh Padesi, our immediate past President of AMOGS, Secretary AMOGS, Dr. Bipin Pandit, Secretary IMA Maharashtra State, Dr. Anil Awad, for accepting the invite and of course gracing the occasion. Warm welcome to our esteemed speaker, Dr. Uday Thanawala, past chairperson of ICOG, our academic wing of Foxy, Professor Dr. Anil Sakre as expert, Chairperson Dr. Lalita Bajaj, President of Aurangabad, Shalini Karad, President of Beed, Dr. Meghashri Deshmukh, President of Nanded, and Dr. Purnima Yande, immediate past President of Beed. Our learned panelists, Professor Lakshmi Rajkunda, Dr. Jayashree More, Aparna Raul, Dr. Sunita Kelkar, Bhagyashri Ranjwan, Dr. Rupali Gaikwad, Dr. Vinod Ojwal, Dr. Priya Ora, Pranjal Joshi, and of course our conveners, Dr. Jairani from Chennai and Rajendra Tiwari from Palghar. Our coordinators, my young friends, Dr. Monica, who is ever active, and of course Dr. Madan. As you know, this AMOGS Emergency Obstetric Committee, it deals with not only the obstetric emergencies, but also the medical emergencies, because we have the prime aim of updating our members and provide the skills of tackling all types of emergencies those contribute to maternal mortality, maternal as well as perinatal mortality and morbidity. And so hematological problems, that is what the topic we have chosen today. I hope this becomes useful for all of you. So wish you all a very happy learning. But before introducing our president, I just make an humble appeal to all of you to support my candidature, not only support, but cast your maximum votes to make me win. So with this, I thank all of you, and I take this opportunity to welcome and invite our AMOGS president for his welcome address. Dr. Kiran Kurtakoti, a very dear friend we know since long, and of course, he has headed Foxy MTP committee and lots of colleagues to his credit. I think we straightway listen to his precious words. Over to you, Dr. Kiran.
Thank you, Sneha. Thank you so much. Today, chief guest, my co-chief guest, Dr. Santoshi Kadam. It's fortunate that AMOGS is always has got a good liaison between IMA, and we thank IMA for the same. IMA, of course, all of us are members of IMA. Lot of elections coming up, and I'm fully aware of that. Santosh Kadam, hello from all of us. Today's guests of ours, Dr. Pardeshi sir, Dr. Pardeshi, Dr. Bipin, and Dr. Anil Abad, and of course, convener Dr. Jairani and Dr. Rajendra Tiwari. AMOGS is so fortunate to be associated with also IMA and also with ICOG. I see Uday Thanawala, past chairperson of the ICOG. We had a fantastic conference with ICOG about a week back. And ICOG always has been, all of us practically are members of ICOG. And thank you, ICOG, again, because for granting points for our MCOG course in cosmetic gynecology. So that's a good thing. First time this has happened from the AMOGS forum. So, and Sneha, what can I say about you? I think you have traveled India. If at all you take a thread, I think it will travel around the globe 2 times at least. So such is the reach of yours, and you have done fantastic work as the EMOC chairperson of AMOGS, and I really look forward to seeing you as the vice president of our esteemed organization. So thank you, Sneha, for that. And I look forward to the webinar, and of course, wish you all the best. And thank you, Monica, thank you, Madan, and thank you, everyone, for involving AMOGS here. Thank you.
Thank you, sir.
Thank you so much, Kiran, for your precious words and of course the best wishes. Yes, Monica.
Ma'am, I also request you to please introduce our chief guest, Dr. Santosh Kadam, sir, as IMA also is a part of this webinar, and we are very proud to be associated with IMA.
Yeah, it is a privilege indeed to introduce Dr. Santosh Kadam, who is the president of IMA Maharashtra, and of course, he was the honorary secretary of IMA Maharashtra. He was a president of Indian Academy of Pediatrics, Thane, and vice president of IMA. Of course, lots of posts he is holding, but yes, definitely we have to appreciate the amount of work IMA is doing, and of course, we have Dr. Santosh Kadam with us to talk about it. Over to you, Dr. Santosh.
Thank you, Sneha Madam. Good evening to everybody. Thank you, Sneha Madam, for inviting me for today's webinar. And as rightly said by Kiran sir, the president of AMOGS, we are associated for the webinars since last 1 year when Dr. Revti was at the helm of affairs, and we did a lot of webinars. So we have to have, we should be associated with webinars and all. And I came to know under the leadership of Dr. Kiran Kurtakoti and Dr. Bipin Pandit, AMOGS conference at Chandrapur was a very big successful conference. Just now I came from High Court, and let me tell you that homeopathy doctors who are trying to take the backdoor into our Maharashtra Medical Council register. So we are filing the writ petition in the High Court already. We could help them by getting the entry into the Maharashtra Medical Council. So we have over here Dr. Bipin Pandit, who is the secretary of AMOGS and my colleague in the Maharashtra Medical Council in 2009. Apart from Dr. Pardeshi sir, who is a past president of AMOGS, Dr. Anil Sakre, who is my classmate, and the Dr. Shalini Kadare, I think she is the president of BEAD AMOGS, as well as the host are 2 more branches, that is Chhatrapati Sambhajinagar and Nanded. So today's topic is very good, and our very own Dr. Madan Kamble is also there, who is going to be president of his branch soon. And Dr. Sneha Madam is also handling our HPV vaccination. We had a online meeting yesterday. So let me congratulate for this webinar, and thank you. Jai Hind, Jai IMA.
Thank you, sir. Thank you for gracing this occasion and being there with us for this webinar today. Dr. Bipin Pandit sir will not be able to join, so I request Dr. Jiarani madam to please introduce our guest of honor, Dr. Rajendra Pardeshi sir.
Thank you, Monica. Thank you, Sneha, for making me a part of AMOGS, which is always close to my heart. I'm very honored to be here with all the doyens of your AMOGS, especially the chief guest, Dr. Kiran sir, Dr. Santosh Kadam sir, and the guest of honor, Dr. Rajendra sir, Singh Paradesi sir, Dr. Pipin sir, and Dr. Anil Awad, and all my friends and the president and secretary of Aurangabad lead Nanded societies, and all the senior faculties from the IMA of Maharashtra. It gives me a great pleasure and honor to introduce Dr. Rajendra Singh Paradesi sir, who is a very nice person, a person who is known for his simplicity, for his knowledge, and also for his kindness, who was the past vice president, and also who has been a great academician, presenting more than 28 papers in national and international conferences.
It's
and
okay, Jairani.
Past vice president of FOXI and also the past president of AMOGS. Sir, over to you for your wishes, which are very much needed for all our work in FOXI as well as AMOGS, sir.
Good afternoon, everybody. Namaste, namaskar. Chief guest, respected chief guest, Dr. Kiran Kurtakoti sir, Dr. Santosh Kadam sir, the guest of honors, Bipin Pandit sir, Anil Awad, coordinators, Dr. Jayarani Kamraj, Dr. Rajendra Tiwari, then coordinators, Dr. Monica Umbardhan and Madan Kamble. I wish to congratulate first to Dr. Sneha Buyar and all coordinators for organizing this program on hematological disorders and thromboprophylaxis, because this is really a need of our to look after these hematological disorders and thromboprophylaxis. We don't know, but many times unaware of that, and complications are more after delivery if we do not look after this and we do not detect these disorders. So Dr. Sneha Buyar is doing really nice work with the galaxy of speakers like Uday Thanawala, then Sneha Buyar, Dr. Anil Sakre, and all panelists. I think this is going to be a great webinar. Dr. Santosh Kadam is there. He is a great leader. We need leaders like Dr. Santosh Kadam again in MMC, Maharashtra Medical Council, and Dr. Sneha Buyar as Vice President. So, and Dr. Jayarani Kamraj and Monica Obardhan for chairperson in FOXI. So I wish all of them every success in their endeavor in FOXI and Maharashtra Medical Council. So I wish every success to this webinar. Thank you so much for inviting me. Thank you, Sneha.
Thank you, Rajput
Thank you, sir. It is all. Yes, sir. Santosh sir, please.
I just want to take a few seconds. Just my humble request that AMOGS and FOXI please support the IMA panel.
Yes, sir.
Thank you.
Positively. And we cannot forget Santosh Kadam sir. He must not be knowing. He was very helping hand for us. Even after that 2010, the credit points and then allocations, accreditation ops. So we used to trouble him a lot, many times. Thank you, sir.
That is my duty, sir. That I like.
Yes,
Thank you.
Yes. We need leader like Dr. Santosh Kadam. Thank you, sir. Thank you.
Thank you, sir. I would now request Dr. Rajendra Tiwari, sir, to please introduce Dr. Anil Awad, sir, our guest of honor. Tiwari, sir, have you joined?
Hello, Rajendra.
Hello. Yes, ma'am, I'm there.
Yes, ma'am. Yes, ma'am. Sir, can you please introduce our guest of honor, Dr. Anil Awad, sir?
Yes, sir. Dr. Anil Awad, sir, is a good friend of us and he's a senior leader of IMA. He was president of Mumbai IMA branch, as well as he's at present secretary of Maharashtra IMA. He's undergraduate from Nair Hospital and he's a leading practitioner in Mumbai. He has many prizes and accolades at his hand, which at present I'm not having. But sir is a very humble. One thing I can say, sir is a very humble, well studied, and leader who makes leaders around him. That's what I can sum up about sir. Sir is there.
That's the best thing. I think any leader can have the quality. So
yeah, he creates leaders around him.
Welcome, sir. Yes. Please unmute yourself.
Yeah, okay. Yeah, good evening, everyone. Thank you very much, AMOGS, for inviting me for this very wonderful webinar on hematological disorders in pregnancy. As our uh, 1 minute, yeah. Sir has said, Padesi sir has already said it is one very important topic during pregnancy because anemia is one of the very leading cause of problems during pregnancy. I may not be the right person because I'm a family physician, but yeah, I can see whole big people from AMOGS and other association. We have our president, Dr. Santosh Kadam, and then we have Dr. Kiran Koti, president of AMOGS, and our own Sneha madam. So I wish all the best for this webinar, and not to forget vote IMA panel. That is the most important thing which I can tell you on this platform. Jai IMA. Thank you very much.
Yeah,
Thank you, sir.
Yes.
Yes.
Monica, go ahead.
Yes. Thank you, sir. With the blessings of Dr. Kiran sir, Dr. Santosh Kadam sir, Dr. Anil Awad sir, and Padeshi sir, we will take blessings from Bipin Pandit sir as and when sir joins, and I declare that the inauguration is over. So now let us move forward for the academic session. And I would take privilege in introducing our chairpersons, Dr. Lalita Bajaj madam, Dr. Shalini Karat, Dr. Purnima Yande, and Dr. Meghashri for this talk. Dr. Lalita Bajaj madam is a practicing obstetrician and gynecologist at Aurangabad since last 25 years, and currently she's the president of the Aurangabad OBGYN Society. Her areas of interest include high-risk obstetrics. We welcome you, ma'am. Our next chairperson is Dr. Shalini Karat madam. She's a practicing consultant since last 25 years and currently the president of BEAD OBGYN Society. She's also a member of the PCPDT committee of IMA Maharashtra and a past member of Child Rights Commission Maharashtra State. We welcome you, ma'am. Our next chairperson is Dr. Purnima Yande madam, director of Sri Kripalu Hospital at BEAD, currently practicing since last 20 years and the secretary of the BEAD OBGYN Society. We welcome you, ma'am. And Dr. Meghashri Deshmukh madam is the president of the Nanded OBGYN Society. She has undergone an advanced training in infertility from Chennai Fertility Center. We welcome you, ma'am, and I would like Dr. Meghashri madam to introduce our speaker, Dr. Uday Thanawala, sir. Meghashri ma'am, please unmute yourself.
Can you hear me?
Yes, ma'am.
Thank you, madam, for these kind words. First of all, I would like to thank Sandhya Bhoyar madam, Sneha Bhoyar madam, Kiran Koti sir, then Monica madam, as well as Santosh Kadam sir, and maximum speakers who are really prestigious and who have eminent knowledge, and that knowledge would be spread amongst all the Foxians, I feel. So I'm really privileged to introduce Uday Thanawala sir. I'm again thankful to all the eminent speakers and eminent chairpersons, as well as the Foxy chairpersons who have invited me for this webinar. Dr. Uday Thanawala, he's a consultant obstetrician and gynecologist at Navi Mumbai, chairperson of Indian College of Obstetrics and Gynecology, 2021-22, vice president, Federation of Obstetrics and Gynecology.
You're muted again, Meghashri. So I think that's good enough.
Treasurer, PCO Society of India, chairperson, Medical Disorder of Pregnancy, Committee of Foxy, 2000-2008, founder, secretary, and past president of Navi Mumbai, obstetric and gynae.
Yeah.
Joint secretary, Foxy, gold medal in FCPS exam, Sir J.M. Masani Prizes of Best Research Paper, 1981-1982, Dr. D.K. Datta Award for Best Journal Publication. I hope we will have an academic feast with such good speakers. Thank you.
Thank you so much, Meghashri, for that lovely introduction. And thank you, Sneha, for having me here. And Monica, and lovely to see Rajendra Singh Pardesi and Kiran Kurtakoti and all the others, including so many friends here. I will not repeat the name again. So thank you very much, Sneha. And Sneha is very, very particular about what one should speak on when she gives a topic. She says, I want you to talk on the rational use of heparin in pregnancy because it's becoming a little rampant. People are using it anyhow. What is actually, when is it indicated and when to use heparin? So that is what I thought. Okay, I don't know if I can share. Can you see my screen?
So not yet.
Yeah. I think, have you clicked on share icons, share screen icon, sir?
Yeah, I
Share
did.
screen.
I did. I did. I
Saiti?
entire screen. I've said the entire screen.
Saiti, can you help sir with it?
Open system settings.
I think that's with the device, your device.
Okay, one
But
minute. One
if you
minute.
directly,
Yeah.
yeah.
Oh, I'll have to, I think, leave and come again or something. It's saying.
All right, sir. Saiti, can you help sir with the technical?
Wait, can you see the share screen icon? Usually, what
No,
is
I know
in
that. I know
green
that,
color?
Sneha, I've done it, but this is a new
That you
laptop.
must be doing regularly.
There is some.
Okay. Sahiti?
Ma'am, in the meantime,
Yeah,
can we ask Lalita madam and Shalini madam to give us a little update about the topic, about
Yes,
brief introduction?
definitely.
Yes.
Yes. Hello, Dr. Lalita. Madam, good evening.
Good evening.
Can we hear from something from you? But let me see whether sir can share his screen.
Yes, looking towards the today's topic, that thromboprophylaxis during the pregnancy, it is really nowadays very much in bad obstetric history. The importance of it is very much high, because in the bad obstetric, repeated pregnancy loss, early pregnancy loss, low dose of heparin does work, and after complete investigation, aplar disease or something comes, then the importance of heparin is high. And post delivery also, this we are discussing.
Yes, perfect. Uday sir, we can see your screen and it is full screen. No problem.
Lalita ma'am, can you complete your sentence? Yes.
No, now we can start with this. After listening only, I will give my opinion.
Okay, all right. Sure, ma'am.
Yes. Uday sir, please go ahead. Please unmute. Please unmute.
Okay. Is that better now? Can you hear me?
Yes, sir.
Yes.
So when we talk about the use of thromboprophylaxis in obstetrics, we basically are looking at, let's take some clinical situations when heparin can be used. So there is a case after 8 consecutive miscarriages, patient A has a recurrent miscarriage screening. All the blood tests what you have asked for come back normal. She inquires, what about the medication to use in subsequent pregnancy? So will you use heparin for that patient? Will you think of using heparin? Patient B presents with a positive pregnancy test. She has had 2 DVTs in the past 7 years. Will you use heparin for her? Patient C is pregnant for the first time. Her sister is positive for APS and has aspirin and heparin treatment after 4 pregnancy losses. That's the sister. Patient D is diagnosed with APS and has had 3 miscarriages. Now she's 5.3 weeks. And a 6-week duration in the postpartum for a patient E who is heterozygous for a factor V allele. So which of these cases do you think require heparin usage? So the first patient who has had 8 miscarriages, but since all the reports are normal, no, you're not going to use heparin. That is what the recommendations state till today. Whatever evidence we have, they say that if there's no APLA positive, nothing detected, then there's no point in using heparin. If a patient has had 2 DVTs in the past, obviously she will be put on heparin. Patient C is pregnant for the first time. Her sister may be positive for APS, but APS is not a familial thing. It will not be passed on to the sister, so there's no point in using heparin for this particular patient. Patient D is diagnosed with APS. Now we have a blood test which says APS positive. She's had miscarriages and now she's 5.3. Obviously, you will put this patient on heparin. And a 6-week duration in a postpartum patient E who's heterozygous for factor V Leiden, yes, we will use heparin. So this is where we have to use and juggle and think and to use heparin. So today we will cover up some things about RPL, when to use heparin, when to start, which one to use, when to stop. Now, in a patient with previous 3 abortions, all 3 were first trimester abortions at 6 to 11 weeks, and she comes and asks you, what are the chances of me having a normal child? This is a regular patient, no investigations done. She just comes and asks you one simple question, what are the chances of me having a normal child? Now, from the history only, you can give us some amount of prognosis. You can say the chances of having a repeat abortion after one spontaneous abortion is 15%. It remains as a regular 15% rate in a regular population. Even for the first abortion, it is 15%. For the second, is 15%. If she's at 2 consecutive abortions, the chances go up to 25 to 30%. And after 3 consecutive abortions, the chances of her having a 4th abortion go up to 33 to 45%. But even if patient has had multiple losses, her future risk doesn't rise beyond 30 to 35%. So there is a good chance that a patient will conceive and have a full-term baby. So after investigations, basically, if you investigate this patient, you can find a contributing factor in about 40 to 50% of the time. When treated, the prognosis is successfully, pregnancy outcome is there for about 80% of the time. If you pick up in a patient of RPL, you pick up a septum, or you pick up uterine malformation, or you pick up APLA positive, well, there's a good 70 to 80% of the chance once you treat her, the pregnancy will be successful. Even in couples where there is no underlying problem is found, the chances of a successful pregnancy can be typically in the range of 50 to 70%. So first thing we have to deal with these patients with recurrent miscarriages is give them hope that it is not all very bleak. It looks very bleak because you have suffered 2 or 3 abortions, but at the same time, it is not very bleak and you can have a successful pregnancy. And this is the breakdown of the factors: genetic, anatomical, autoimmune, infection, endocrine, and of course, 40 to 50% are unexplained, including the non-APS thrombophilias and thrombophilia. So today we will stick to thrombophilias, but if no conclusive positive test, can we give empirical anticoagulant treatment based on the history only? All the studies till now, like the SPIN study and the ALIVE study, say that no, there is no benefit of giving a anticoagulant therapy to patients when there is no positive test. That's till now. We'll see as there is some now recent data coming up, and I'll share that with you. So when you talk of thrombophilias, what are we talking about? We are talking about the acquired thrombophilia, like the antiphospholipid antibody syndrome, the inherited thrombophilias like activated protein C resistance, factor V Leiden mutation, prothrombin gene mutation, protein S deficiency, protein C deficiency, antithrombin 3 deficiency, hyperhomocystinemia, and homozygous methylene tetrahydrofolate reductase deficiency. So these are all the inherited thrombophilias which are there. When you talk about antiphospholipid antibody syndrome, because that is the main thing which we obstetricians are concerned with, because that is something which we can treat pretty successfully, we have 2 components to it. One is the vascular thrombosis, and second is the pregnancy morbidity. So one is the patient has a history of vascular thrombosis in the past, and in the pregnancy morbidity, it is 3 or more unexplained consecutive miscarriages with anatomical, genetic, or hormonal causes excluded, 1 or more unexplained deaths of a morphologically normal fetus at or after the 10th week of gestation, and 1 or more premature births of a morphologically normal neonate at or before the 34th week of gestation associated with severe preeclampsia and severe placental insufficiency. So that is the definition. That is the where we have to fit into our patients if they give a history of a pregnancy loss. Does it fall into any of these? And then if it does fall into it, we ask for laboratory investigations. Sorry. And one is you do the anti-cardiolipin antibody, IgG, IgM, and you do the lupus anticoagulant test, which we generally do by the dilute Russell Viper venom test. And we also do anti-beta-2 glycoprotein, IgG, IgM. So anti-2 glycoprotein is a recent thing. Initially thought that the autoantibodies are against phospholipids in cell membranes, but it is now known that they actually recognize and bind to certain blood proteins which bind to the phospholipids and not phospholipid in themselves. And that is why we need to do beta-2 glycoprotein, anti-cardiolipin antibodies, and the dilute Russell Viper venom test to see if the patient has any lupus anticoagulant present or not. What is Sapporo's criteria? APS is defined by one clinical criteria of either vascular thrombosis or a fetal morbidity, and one immunological criteria of either lupus anticoagulant or cardiolipin antibody present. So you need to have, if the patient fits into the history of having, say, one abortion or after 10 weeks of gestation, etc., plus any of the other criteria, and one of these things like beta-2 glycoprotein positive or anti-cardiolipin positive, then yes, you are dealing with APLA, and you should definitely then start treating the woman. So for women with RPL, screening is recommended for antiphospholipid antibody after 2 pregnancy losses, according to the recent ASHRAE 2022 guideline. Sorry. And screening for beta-2 glycoprotein can be considered also after 2 pregnancy losses. So now let's look at this clinical situation. A gravida 5 comes at 6 weeks of pregnancy. She has had 1 missed abortion at 9 weeks. Second, chemical pregnancy. Third, ectopic pregnancy, LAF self-injectomy was done. When she came again, we did an HSG to confirm whether the tube is patent or no. The cavity was normal and the right tube was patent. She conceived again but had a missed abortion at 10 weeks, and of which the karyotype was normal. So basically this patient technically would have 2 previous abortions, because a chemical pregnancy and an ectopic pregnancy is not considered in the definition of recurrent pregnancy loss. So we investigated her, and a DRVVT came positive. The lupus anticoagulant was positive. And the way the antiphospholipid antibodies act is they bind to the trophoblast, exaggerating complement activity, stimulate inflammatory cells, and cause injury to the developing uteroplacental unit, probably resulting from thrombosis in the uteroplacental circulation. So that's how it's acting. And that is why is treatment needed once you find APL is positive. If you don't treat these women with any pharmacological intervention, the success rate is as low as 10%. So that is why in obstetric antiphospholipid syndrome, where there's no other vascular element, but she has a history of any obstetric loss plus some blood test positive, you get a very good result in women whom they are treated. And basically the treatment is to start aspirin and heparin. So aspirin and a prophylactic dose of low molecular weight heparin is started as soon as the pregnancy is confirmed. A very important point. When they come to the positive pregnancy test, please start aspirin and heparin. The rationale for using heparin is that this drug, apart from its anticoagulant action, seems to promote successful implantation in early pregnancy. And the various explanations are there, but many people clinically feel unless a gestational sac is seen, they will not start heparin, because suppose it's an ectopic, but that is all supposition. Technically, by the book, we are supposed to start aspirin and heparin the moment the pregnancy test comes positive. So what is the dose which we use for heparin, and what are the advantages of low molecular weight heparin over unfractionated heparin? What are the side effects? When do you start and when do you stop? Let's look at that. So basically, when you compare low molecular weight heparin with the regular unfractionated heparin, basically the results is more or less same, 84% and 80% viable infants, and both are equally effective. So you have the choice of using either low molecular weight heparin or unfractionated heparin also, because unfractionated heparin is very, very cheap and it can be used. And but low molecular weight heparin does offer a number of advantages over unfractionated heparin. That is, it's got equivalent efficacy. It has got once daily dosing. That's all. Lower risk of heparin-induced thrombocytopenia and osteoporosis, and less intensive monitoring. So it can be, you can use low molecular weight heparin or unfractionated heparin, but basically it has an advantage of a single dose every day, which women find very convenient. Sorry. So what is the dose of low molecular weight heparin? You use enoxaparin 40 milligrams a day subcutaneous, or deltaparin 5,000 international units a day per subcutaneous. We basically have more or less enoxaparin available, so we use 40 per day. If you want to use unfractionated heparin, and many of our patients who don't afford low molecular weight heparin, one can use it. You can simply use 5,000 units twice daily in the first trimester, 7,500 units in the second trimester, and 10,000 units twice daily in the third trimester. Sorry. If the patient has had a history of vascular thrombosis and is APLA positive, then you need to change the dose and give full anticoagulation, where you will increase the dose of enoxaparin to 1 milligram per kilogram every 12 hours. And unfractionated heparin also proportionately goes subcutaneous doses of 12 or 8-hourly intervals, so as to obtain a PPT 2 times the patient normal. So that is when the calculation comes in, if she's got a history of a vascular event in addition to being APLA positive and a bad obstetric history. How do you monitor low molecular weight heparin and unfractionated heparin? Unfractionated heparin is simple. You can do an activated partial prothrombin time. Low molecular weight is difficult to monitor, and that is where the disadvantage is. But in general, like we can't do anti-factor 10A activity in all our patients just to monitor the effect of heparin. We generally don't do anything. They don't have much of a problem. So many patients have been on low molecular weight heparin, and we generally don't monitor too much in these patients. Side effects of long-term use, well, you have to be a little careful about the bone loss, and you should supplement with calcium and vitamin D. Very rarely thrombocytopenia occurs, which could be either the immediate type or the late onset type, but generally it takes care of itself. It doesn't require discontinuation of therapy. When do we stop heparin and aspirin? Basically, electively stopping low molecular weight heparin 24 hours before planned induction of labor is recommended. Electively stopping prophylactic low dose molecular weight heparin or unfractionated heparin at about 38 weeks of gestation, and to await spontaneous labor. Or more effective is switching the therapeutic unfractionated heparin at about 36 weeks with and to unfractionated heparin. Means you, from low molecular weight heparin, you can switch over at 36 weeks to the unfractionated heparin, and tell the patient to discontinue if she goes into labor. And the additional advantage of unfractionated heparin is to monitor it's easy to monitor, and you can completely reverse the effects of this heparin with protamine sulfate if you need. But in generally, if you stop it at around 36 to 38 weeks, and we are going to interfere at 38 or 39 weeks, it generally doesn't matter. It doesn't matter if the patient doesn't take it for a week or so in the late pregnancy. But in general, at 36 to 38 weeks is the time when we say that, okay, one can probably stop heparin and aspirin. And maybe in cases which are very high risk or with some positive, 24 hours before planned induction of labor or a cesarean. Let's talk a bit about inherent thrombophilias, because there's always a thing, what shall we do? Shall we screen for it? Shall we not screen for it? And what does it cause? We have talked so much about the acquired form, the APLA, which we know so much about. But a meta-analysis of retrospective studies has reported a strong association between second trimester miscarriage and inherent thrombophilias, like factor V laden, prothrombin gene mutation, and protein S deficiency. So basically, they are more implicated in second trimester losses. And that is why it is recommended by some forces that at the second trimester miscarriage, you can screen for inherent thrombophilia, including factor V laden and prothrombin gene mutation and protein S. So basically, we do protein S, protein C, factor V laden. And basically, there are two types of inherent thrombophilias. One is the low risk inherent thrombophilias, that is less than 1% risk of VTE in a pregnant patient without a personal history of VTE. And that is the heterozygous factor V laden, which is very, very rare in us Asian population. Protein S deficiency and a protein C deficiency. And you have a high thrombophilias, which has got a greater than 1% risk of VET in pregnant patients, and even those without a personal history of VET. And those are the homozygous factor V latent, homozygous prothrombin, and compound heterozygous V latent with prothrombin mutation and antithrombin deficiency. Now, the problem with this test is if you ask even for factor V latent, say, activity and protein S activity, the cost of the investigations is somewhat prohibitive to most of our patients, because I think costs around $15,000 to do the test. So basically, we don't know whether it is worth screening for inherent thrombophilias. But this is the other thrombophilia of uncertain significance. So what does ASHRAE recommend? ASHRAE 2022 recommends that women with RPL screening is not recommended for hereditary thrombophilia unless in the context of research. So basically, it is not recommended to screen for these hereditary thrombophilias. And the second question is, does heparin and aspirin even work in these? There was enough, earlier there was a lot of confusion that heparin and aspirin may not even help. So the live birth rate in women treated with enoxaparin was 86% compared to 29% taking only low dose aspirin. This was one randomized trial way back in 2004. So that is when it was propagated that heparin therapy may improve the live birth rate in women with second trimester miscarriage associated with inherent thrombophilias. But there is insufficient evidence to evaluate the effect of heparin in pregnancy to prevent a miscarriage in women with recurrent first trimester miscarriage associated with inherent thrombophilia. So first trimester miscarriages don't even think of doing any tests for inherent thrombophilias. If the patient has got only second trimester loss, and if your patient can afford it, then you can do tests for inherent thrombophilia. And if it comes positive, you may put the patient on heparin. That is what it means. And let's see some clinical case which will help us to further help us in the heparin therapy. A 36-year-old woman, multipara, presents in early labor at 5 a.m. She has a history of DVT at 28 weeks of pregnancy, is on therapeutic doses of low molecular weight heparin. The last dose she had taken at 8 p.m. last evening. The current gestation is 35 weeks, and her previous 2 deliveries were both induced for post-maturity. Cervix is effaced but not dilated, and this patient demands an epidural. What are you going to do? Are you going to check the APTT levels? If normal, she can have an epidural? Probably yes. Advise her that it is fine. She can have it after 8 a.m. if she labors. Well, this will be no, because there's only a 12-hour gap. We want a 24-hour gap between the last dose and giving her an epidural. So this is not true. Advise her that it would not be safe to insert an epidural until 24 hours after the last dose. So not to inject anymore and admit and observe her. Yes. Admit her and change to unfractionated heparin. Yes, you can do that. And advise her to have no further heparin till after delivery to reduce the risk of bleeding. Well, this will not be true because basically as the patient has had a DVT, like this patient has a previous history of DVT. So we can't take the chance. She's had DVT herself at 28 weeks of pregnancy. So that is about the use of heparin in pregnancy. And to sum it up all, today heparin is 100% indicated in patients of recurrent pregnancy loss with a positive APLA syndrome. Question mark if it is a second trimester loss with inherent thrombophilias. We don't know, but many people do use it. Beyond that, it doesn't. It really is not required because this is the indications given here. In women with a history of antiphospholipid antibodies and previous history of pregnancy loss, it is recommended to use prophylactic doses of anticoagulant. Whereas those with the inherent thrombophilia and previous history of pregnancy loss, it is less clear-cut if the anticoagulant should be recommended. For women with thrombophilia, a history of late fetal loss or stillbirth, placental abruption, or fetal growth delay, the use of anticoagulant should be reviewed on a case-to-case basis with no clear recommendations for its use. So be a little careful if you're just going to use it empirically. And then another recent paper which has come out is, what about unexplained pregnancy loss? We've done everything. All tests are negative, etc., like our patient with 8 previous abortions. This paper says that unexplained pregnancy loss, the spontaneous loss of 3 or more consecutive pregnancies without any identifiable risk factor, remains a significant challenge. Low molecular weight heparin is now being used to treat this due to anticoagulants and anti-inflammatory effect. Its use is associated with substantial improvement in live births in most studies reviewed, but few studies are inconclusive. There was no significant improvement in late pregnancy complications when treated with low molecular weight heparin. So what it means is, what we people are doing is not totally wrong. Sometimes there's a patient with 4 or 5 abortions, we don't know what to do next, and we say aspirin heparin leke dekhte hai. Maybe it is not totally wrong as yet, but the evidence has yet to come in. It has yet to come in whether we can use it when we have got nothing positive. So till then, these are the indications for use of heparin. This is how you use heparin. And thank you very much.
Yes, I think chairperson to comment first. Yeah.
Yes. It was excellent talk by Dr. Thanawala sir. It was pleasure to listen to him. The topic was very complicated that way, thromboprophylaxis in pregnancy. But sir has explained everything case-wise basis. In first trimester, how we should investigate and diagnose and which patient are in need of low molecular weight heparin. In the second trimester also, when to use. Sir has explained very nicely the indication for the low molecular weight heparin and how to improve the fetal outcome. So thank you very much, sir. It's pleasure to listen to you.
Thank you very much. Thank you, Sneha.
Sir, I have
Thank you, sir. You have explained so nicely, because the cases are now increasing more and more, and in rural areas, and haphazardly without any pathological tests, just some general practitioners are prescribing just low molecular weight to all the patients who have undergone 1, 2 abortion previously. It was very nice, excellent talk, sir. When to use and when not to use.
So I have a query.
Yes, sure.
Yes, I would like to know, we do IVF for all patients or ICSI for indicated patients, and we put them on low molecular weight heparin. And these patients land up with threatened abortion many a times. They have twins, the one twin is absorbed, the other twin is there. But patients come with threatened abortion. In these cases, if fertility is normal, should we continue with low molecular heparin and icosapent in this patient, or should we stop at active bleeding? That is a query in my mind.
So Megashri, if you are going to, like even I have an IVF clinic, and we generally, we start heparin sometimes just to facilitate implantation. There is no other role of heparin. She doesn't have APLA positive. She doesn't have a bad study history. अपने को है कि कैसे भी करके implant होना चाहिए. So we give everything. We give vitamin D, we give Visalon, we give everything. So I had read about this, and they said there's no role of heparin. There is no role of heparin or steroids in patients who are normal, who have no history of any previous losses, to be given to patients just to facilitate implantation. And also it says that, yes, if like there is a study where they have stopped even estrogen and progesterone at 6 weeks. See, we are giving progesterone support till 12 weeks. Pregnant हो तो 12 हफ्ते तक चालू रखो estrogen progesterone. But there is enough evidence now which has come because there are papers which have stopped at 6 weeks. There are papers which have stopped when urinary UPT comes positive. But the consensus now is at 8 weeks, you should start weaning off, and by 9 weeks, you should stop all support. And they have said that, yes, once you do that, there is a little bit increased of threatened abortions, but the patients may bleed a little bit more. The incidence is more in patients bleeding, but the pregnancy continuation rates are the same.
But should we stop heparin, icosapent?
We should stop heparin if she's bleeding.
Yeah,
we should, especially if it is a patient with APLA negative, stop. Now, if you have a with APLA positive,
positive,
If
then you have to
you're
continue.
APLA positive, stop heparin till that time when the bleeding stops. 24 hours to 48 hours, there's no
48
bleeding.
hours.
You can start again.
Restart after 48 hours if they
Yeah,
stop.
after 48 hours, but only in
Yes.
indicated cases. I think we are just doing too much. Even I have a IVF clinic, so I agree with you. Most of us, all of us are
Yeah.
starting giving everything till 12 weeks. बहुत ज़्यादा कर रहे हैं हम लोग. We should start now weaning off earlier at 8 to 9 weeks is what is recommended.
And estrogen also should be stopped. Estrogen hemohydrate after 10 weeks. I think so.
Estrogen, at least I'm giving only in cases of FET where we are preparing the endometrium in natural cycle, in natural these things we don't give, but estrogen also you have to be very
chances are
careful.
high. Yeah.
We stop estrogen also because be careful, estrogen can cause further problems, high blood pressure, high sugar,
Hypertension
etc.
and yeah.
You have
Thank
to
you,
be
sir.
careful of. Thank you.
Thank you.
So that was an excellent, exhaustive talk, I would say, Uday sir. What I agree with Dr. Lalita Bajaj that, it is a complicated topic, but you have made it so simple that, you have considered each and every scenario individually. So that is how it is going to help all the clinicians who are watching this program. So I'm very happy about it. And of course, the empirical use of heparin, that's a very, very debatable question all the time.
Topic which is coming up because there's a thing in the chat blocks. What about seronegative APLA? Can you please tell us more about it? And are we justified in giving heparin to women who had a loss of structurally normal fetus in the second trimester with history of preeclampsia in the previous pregnancy? Technically, you're not justifiable to give heparin to this patient because she is seronegative for APLA. If you feel it's a second trimester abortion, and if you feel that you need to do the inherent thrombophilias, do a factor V laden protein S, and then if anything comes positive, then 100% put her on heparin. Because we can't do it to all our patients. If you have patients with 2 or 3 second trimester losses, maybe empirically, I mean, I should not be saying this on this platform, but I don't know whether we can give heparin to these patients, whether it'll benefit or no. Because some of the patients who are not affording, what do you do to them, because 2 or 3 pregnancy losses like sudden rupture of membranes, 26 weeks, you've taken a stitch. In spite of that, the patient has a loss. So those are the patients which are very, very tricky, and you really suspect, is there an inherent thrombophilia working in the background? So technically speaking, please do the test, confirm that there is an inherent thrombophilia. Then also maybe heparin can act because it's not conclusive that heparin will help in inherent thrombophilia. So this is all a very long thing to do, whether to start. And this one, though, I don't think if it was history of preeclampsia and she's lost a fetus, no, it will probably not help to give heparin. If it's only preeclampsia and APLA is negative, do not give heparin.
Yeah, there's lots of clinical dilemma. Actually, Eshrey says even if you have recurrent pregnancy loss and if it is APLA positive, then only you should give heparin. Otherwise, if it is hereditary thrombophilia and the same history, you should not prescribe heparin unless there is a risk of venous thromboembolism. So I think that point you have covered very well. So I'm sure all of you have got the answers to your queries. If anything, please come up. Otherwise, we can conclude this talk.
Yes, ma'am.
Yeah.
For preeclampsia, ecosprin also low dose.
No, preeclampsia 100%. Your previous history of preeclampsia.
Yes.
This time you do a 12-week, you do an uterine artery PI, and if it is more than 2.6, 2.7, please put her on aspirin 150 anyway.
That will more helpful.
Yes, ma'am.
Aspirin 150 for prevention of preeclampsia is a very, very well documented thing.
Well documented, evidence-based. So I think,
yes, ma'am.
Yeah, thank you so much, Uday sir, for that very, very helpful talk, I would say. And thank you once again for.
Thank you very much. Thank you.
Thank you. So, Monica, over to you.
Yes, ma'am. Thank you, Uday sir, for an excellent academic talk. And I think all the doubts have been cleared. I also thank Dr. Lalita Bajaj, Dr. Shalini ma'am, Dr. Purnima, and Dr. Megashri for chairing this session. And now I hand over the baton to Dr. Madan Kamble, who will be conducting the panel discussion, which is moderated by none other than Dr. Sneha Bhuyar, madam, and the topic is hematological disorders in pregnancy. Over to you, Dr. Madan.
Yes, thank you, Monica. Let us start this session. Next session, which is the panel discussion. Moderator is nothing but our own, the Sneha madam.
I have been introduced, so you can skip.
Yeah. Please next slide, please. Our expert is Dr. Anil Sakre sir, who is the past president of Nanded OBGYN Society, past AMOGS chairperson too. He is a fantastic speaker and vaginal surgeon. Next. Dr. Jayasri More, madam, is from GMC Aurangabad, awarded gold medal in OBGY, senior practitioner in Aurangabad OBGY Society. Now, welcome, ma'am. Yes, next, Dr. Lakshmi Rajkonda, madam. She is a professor and head of the department at MJ Medical College, Sambhajinagar. Also, past president of Aurangabad OBGY Society. She is very active academician. Welcome, ma'am. Next. Dr. Aparna Rahul, ma'am. She is the past president of Aurangabad OBGYN Society, senior practitioner in Aurangabad, infertility practitioner, also past secretary of Aurangabad OBGYN Society. Welcome, ma'am. Dr. Bhagyashree Ranjwan, current secretary of Aurangabad OBGYN Society, past treasurer and managing committee member of AOGS, and also she is a very good academician and orator too. Welcome, ma'am. Yes, Dr. Sunita Khedkar is a consultant and director at Khedkar Hospital, Maternity Hospital at Aurangabad, clinical secretary, cultural secretary of AOGS, and youth coordinator of AMOGS, active member of Aurangabad OBGYN Society. Welcome, Dr. Sunita. Yes, Dr. Rupali Gaikwad, madam, assistant professor, Government Medical College, Chhatrapati Sambhajinagar. She is also undergraduate and PG teacher too, and she has a lot of experience in teaching, working on so many projects. Welcome, ma'am. Dr. Pranjali Joshi, madam. She is practicing OBGYN at Nanded, past treasurer of Nanded OBGYN and also secretary of Nanded OBGYN. Welcome, Joshi, madam. Dr. Vinod Oswal, sir. He is practicing OBGYN at BEAD. Also past secretary of BEAD OBGYN Society, past secretary of BEAD IMA too. Welcome, sir, for this session. Dr. Priya Vora, madam, AMOGS Managing Council member since 10 years, Youth Council mentor since 6 years, Vice President, Mumbai Menopause Society, Secretary, AMWI Mumbai branch, also convener for various conferences, received so many awards and prizes too. Welcome, Priya, ma'am. Yeah, I welcome all the participants of this wonderful panel discussion, and I will hand over to Sneha ma'am for further proceedings. Thank you.
Yes, thank you so much, Madan. I welcome all of you once again. At the inauguration, I have welcomed everybody, but still I welcome all of you. And I just take this opportunity to say that, you know, I'm so sorry. Just so before we go to this clinical discussion, I would just give the introductory part of this webinar, this panel discussion. I'm so sorry. Lots of disturbance from my side, so I'll just make this phone silent. Friends, all of you are managing the pregnant women day in and day out, and I'm sure there are lots and lots of hematological disorders you are facing. Anemia being the most common, more than 50% is the incidence. Pancytopenia, hemoglobinopathies, thrombocytopenia, and thrombophilia, what we just heard about it, the thromboprophylaxis for the same. So anemia, definitely all of you are practicing, managing it, but you have to know what is the evidence-based definition. So by WHO, hemoglobin of less than 11 gram percent for first trimester, less than 10.5 gram percent during second trimester, and less than 11 gram percent again for third trimester. Of course, postpartum, less than 10 gram percent according to WHO. And according to ICMR, 10 to 10.9 as mild, 7 to 9.9 as moderate, 4 to 6.9 as severe, and very severe 4 gram percent. So And why this pregnancy is, causing anemia? Why are we worried so much about it? Because it has got profound effect on the pregnancy, and pregnancy has got the effect on anemia as well. So we are really concerned because each other, they affect a lot. Here during pregnancy, all of you know there are lots of physiological changes. The RBC mass increases by 30%, the plasma volume increases by 40 to 50%, and there is a relative hemodilution leading to drop in hemoglobin percentage by 2 gram %. There is, of course, the peripheral picture remains normocytic, normochromic. And why this is happening? Because the blood has to remain in fluid status. It should move more and more. And of course, the volume, which is increased volume, should be, helpful for the blood loss to be compensated during the third stage of labor. So we go to Dr. Bhagyashree. This is the first question for you, Dr. Bhagyashree. Why there is iron deficiency anemia during pregnancy?
During pregnancy, iron requirement is increased. Total iron requirement in pregnancy is 1000 milligram. Out of that, fetus and placenta 300 milligram. Increased RBC mass is there 500 milligram, and basal loss is 200 milligram. This is first part. And second part, if patient is of low socioeconomic status, then due to faulty dietary habits, there is more iron deficiency anemia during pregnancy. And in some patients, there is misbelief, means they are very much reluctant to take iron tablets also. So it's very common, iron deficiency anemia during pregnancy.
Right. So, Dr. Priya, we come to you. Many a times you see these cases of severe anemia during pregnancy. So do you feel that, they are suffering from severe anemia right from beginning, or, they are evolving, going through all these phases? And how do you come to know what stage she is?
Good evening, madam. Am I audible?
Yes.
Yeah.
Good.
So anemia is in different stages. The initial stage, the earliest is there where is the bone marrow, it gets affected. So there's a depletion in the bone or in the liver.
Iron stores.
Yeah, the iron sources. And so after about it, so this lasts for about few days to few months also, and it's gradual. And the serum ferritin is the earliest change. So there'll be a reduction in the ferritin levels, and gradually then you have the serum iron levels, which will slowly reduce. The TIBC, the total iron binding capacity, increases. The percentage saturation with transferrin also it reduces. And so this occurs in stage 1. Then, and there's a drop in the ferritin levels, as I told you. Then in the second stage, there will be the ferritin levels drop below 15 microgram per DL, and the TIBC increases. And here the bodies, the red cells basically start showing the changes in that. So there's an increase in the red cell protoporphyrin also, and serum transferrin saturation also here it falls. And the third stage is there where actually the HB and the PCV it drops. So we must remember that this occurs much later. So it occurs after the iron reserves of your body are already depleted.
Yes. So it's almost, when you diagnose clinically, it's almost already
late.
the third stage. Okay.
Yes.
So, Dr. Aparna, do we have Dr. Aparna join? I think she has messaged me that she's in an emergency, so anybody can take up this question.
Can I, madam?
Yes, definitely. Dr. Lakshmi.
So about screening of women, yes, definitely, because anemia actually is around more than 50% common during pregnancy, and it is something which we can really prevent. So ideally speaking, it should be started in adolescence only.
Perfect.
That is what the recent guidelines say. But we start screening many times in pregnancy. Like what we learned, we should screen at the first visit whenever she's coming, greater than around 16 weeks, then 24, 28 weeks, 32, 36 weeks, where there is a hemodilution in pregnancy, where anemia is possible. So these are the government guidelines.
Yes. So even the ACOG says, India is a country, poor resource country, low socioeconomic country. Still, definitely we have more than 50%, but even in American women, the anemia is still present. And so ACOG recommends Even in US, it recommends pregnant women to be screened for anemia. So why are we worried so much about anemia? I was talking about how do anemia and pregnancy affect each other? Dr. Aparna, or maybe we can go to the next panelist. Yes, Dr. Megashri. No, not
consequences.
Yeah, Megashri
Yeah.
can take up. Yeah, anybody can take up rather.
Yeah. Consequences of anemia in pregnancy, as you're seeing, antepartum complications, intrapartum and postpartum are there. But the increased risk of preterm labor, preeclampsia, and intercurrent infections are more common in antepartum period. Along with that, intrapartum, you'll see increased rate of operative delivery and induced labor. Fetal distress, because the fetus would be receiving less amount of iron. That's the reason absorption will be less. And postpartum, puerperal sepsis is very common, and you see many Indian females with lactational failure. And postpartum depression is on rise. As mental health, we are giving a lot of importance. You are seeing many patients go for postpartum depression, and subinvolution of fetus due to puerperal sepsis is there. And regarding fetus, you'll see prematurity, infection, and neonatal anemia. According to neonatologists, if you go for HB levels in the neonate, actually 14 to 17 they say it's normal. But when neonatal anemia comes to the mother is already anemic and the baby also becomes anemic. In that case, you have to be very much vigilant in cases of patients who have heart disease, who have Rh negative incompatibility. In this patient, if neonatal anemia is there, you have to be vigilant. Infection, prematurity, and abnormal cognitive development is also seen in these patients, and behavioral development in kids have been seen in patients whose mothers are anemic, and consequently the babies are anemic.
Okay, so Dr. Sunita, can we hear from you? How does anemia gets affected by pregnancy?
In pregnancy, there is hemodilution, so anemia will be more severe. Generally, hemoglobin drops up to 2 gram% in pregnancy. So it will get aggravated.
Yes, and the patient sometimes, if it is very severe, there is a possibility of the patient going into congestive cardiac failure.
Yes, ma'am.
Yes. So, of course,
also nausea vomiting of pregnancy will have a negative impact on iron stores and iron intake.
Right. So basically, each other they affect a lot. Now, with this brief introduction, we now go to the case-based discussion. You have this third gravida. This is a question case for you to discuss, Dr. Sunita. Third gravida, Clara 2. She comes to you with 3 months amenorrhea, complaining of weakness, easy fatigability, breathlessness. There's no complaints of pain in abdomen or bleeding PV, and her vitals are stable. Uterus is, parabdominally soft, non-tender. Uterus is just palpable, and she's carrying the report of only hemoglobin, that is 5 gram%. What is your diagnosis? What other investigations are needed to come to the diagnosis, and how will you manage this case?
Ma'am, this is a case of anemia under investigations.
What degree of anemia?
This is severe anemia, ma'am. HB of 5 to 7.9 is severe anemia. And she is symptomatic also, so she will need prompt investigations and treatment. So for she has previous to live birth. Maybe pregnancy she must have planned too quickly. Iron stores may not have been restored.
No, but we talk about that is now we don't want to go into the details. We want to manage her. How do you, what investigations?
Investigations still need CBC first of all to know the details. Mean corpuscular volume will give idea whether it is microcytic anemia. If it is microcytic, we will see the causes of microcytic anemia as iron deficiency, or we can do beta. We can go for HB electrophoresis. Then,
Madam, can I add something here?
Yes.
If we list the investigation, the first thing is we have only the hemoglobin. So as Sunita said, it is CBC with all the counters like MCV, MCH, MCHC. Then a peripheral sphere. Very important, a peripheral sphere for opinion over here. And once it goes for the stool and urine to know the cause, and then we can go for the next set of investigation like the iron, because we can know the majority. It's a megaloblastic or a microcytic or disease due to chronic. We don't have any history here, so we can go step by step. with the CBC, urine stool, and then peripheral
Well,
smear,
I
which
would
is a
like to
very
interrupt you here, Dr. Lakshmi. What additional information you will be getting from PS, peripheral smear?
One thing is the typing of anemia, then whether there's any type of hemolytic anemias which can be seen.
Fragmented RBCs. That is what I want. Fragmented RBCs.
Fragmentation of the red plasma cells.
Spherocytes.
Yes.
Cystocytes.
Anisopoikilocytosis will
Yes.
be seen.
Maybe even the parasites.
Yes,
malarial
yes,
parasites.
Yes. So well and good. So you get complete blood count
And
you
even, madam, if
get
the platelets
information.
are low,
Yes.
platelets are low, the clumping of platelets can also be.
Thrombocytopenia can be ruled
Yes.
out.
So you can get information not only the hemoglobin hematocrit but also the various cell indices and then of
WBC
course
count and
the
platelet
WBC
also.
count if there is any evidence of infection or whether there is in general the cell counts are less, that is pancytopenia, platelets as you have already said, and if at all you get the idea about iron, you suspect iron deficiency anemia, then you go for the iron profile where you can get the idea about the serum ferritin, which is most important, and the percentage saturation. So here you can differentiate between the iron deficiency, which is on peripheral smear. So whether it is true iron deficiency or whether it is just reflecting as manifesting as iron deficiency, but it has got high iron levels, and there you can now go for hemoglobin electrophoresis. Right?
Hemoglobin electrophoresis should be done.
Yes, so this is actually the same repetition what we have discussed. So,
madam, if this smear is normal and HB smear is normal, then they should go for hemoglobin electrophoresis.
Yes. Okay. So now this is a severe anemia that is symptomatic, as you have already said. You have done all these investigations.
We need blood
now
transfusion.
tell me, Dr. Sunita, yes. 5
we give her packed RBCs.
Yes.
Because she will not tolerate oral as well as parental iron. Parental iron will take time to raise her
So
HB
blood
and
transfusion, you are
symptoms.
very well there.
Yes.
Blood
Blood
hemoglobin
transfusion
of
and
less than 5 gram% any time during pregnancy, especially when she is asymptomatic. That is what the evidence says, that it is an indication for blood transfusion. And then, of course, later on, you can go ahead with various the concentrations of iron, injectable iron. Okay, so which formulation you are using at present? How do you calculate the iron requirement?
we use IV iron, both iron sucrose as well as ferric carboxymaltose. The dose is calculated by the simple formula 2.4 into HB deficit into pre-pregnancy weight plus 500 for the
1000
extra iron storage.
1000 milligram for the stores.
1000 milligram.
For replenish the iron stores, 1000 milligram. This is usually for the iron sucrose we are doing. FCM, how much you are giving and what precaution you are taking for giving the FCM infusion? What is the time period? Yes.
For FCM, if it is 500, we give it in 100 ml NS for 6 minutes, within 6 minutes, and for 1000 within 15 minutes in 250 ml of NS. It has to be given within time because afterwards the efficacy and chances of reaction are there.
Yes, it gets precipitated.
The chillation. Iron should not chillate, so it should finish
Yes.
within 15-20 minutes. That is
perfect. So I think basic case of anemia we have managed. Now we come to the next case, Dr. Jayashree.
Yes.
This is for you. 23-year-old pregnant lady, 28 weeks of period of gestation. She's experiencing this. 8 minutes. Sorry. So since last 4 weeks, she's symptomatic. She's experiencing fatigue and associated history of petechiae, gum bleeding, epistaxis. There's no history of, there's no bruising on the body, no splenomegaly or lymph node enlargement. So vitals are stable, not very much altered, and SpO2 is also 97% at room air. She's got little pallor. What will be your approach and how do you come to the diagnosis?
Looking at the whole history, am I audible, ma'am?
Yes.
Looking at the patient, it appears that she is anemic, and moreover, maybe she has thrombocytopenia because she is showing petechiae and gum bleeding. There is no fever, so it could not be because of some chronic infection. There is tachycardia, again supporting our diagnosis of anemia. So in this case, I would like to do all her investigations as we do in an anemic
So
patient.
when we have done these investigations, I'll just read it out for you. Platelets 15,000, hemoglobin 5.4, MCV 90, MCH 33, MCHC 32, WBC count 4.2, 4,200 with absolute neutrophil count of 61% and RBC 1.69. Coagulation profile, when you do, it was normal. Coombs test is negative and viral markers are also negative for Fanconi anemia also. And bone marrow aspiration showed hypocellular marrow. Okay. Now you tell me what is your diagnosis?
Now, as the platelets are so low, anemia is there. MCV appears to be little on the slightly lower side, but RBC and WBC count are very much reduced. There is no hemolysis because Coombs test is negative. Bone marrow aspiration, moreover, shows hypocellular marrow. So most probably this is a case of pancytopenia.
Yes.
Like the aplastic anemias.
Yes. So now how do you go ahead with the management?
Now, aplastic anemia is though very comparatively a rarer entity for us. In this case, firstly, we'll have to give support to the patient so that her blood parameters are a little better. We maintain the platelets around 50,000 minimum. So that we would like to give. We would like to prevent infections in the intercurrent time.
Yeah. So we'd like to invite Dr. Vinod Otswal from for this question.
Yes, ma'am.
So what are the treatment options? How do you support this patient?
Definitely, ma'am. Good evening. Am I audible, ma'am?
Yes.
Seeing that this is an pancytopenia, definitely we will keep some blood products and blood available for this patient. Especially, we will go for the PCV and donor platelets. We will make the arrangements. We will keep some good antibiotics to prevent infection because she is more prone for the infections. Usually avoid the antiplatelet drugs, avoid intramuscular injections, and also we will see for the some iron chelators if there is a more load of iron, if any, like that.
Iron chelators yeah, definitely you have to have the evidence whether she has iron overload, then you can go ahead with the iron chelators. And as you can see, the platelet count is very, very low. To stimulate the thrombopoiesis, you can give the thrombopoietin as well. Okay, so actually, there are certain drugs to be used. So can you throw some light on these drugs and whether you have any experience of
Definitely.
drugs?
Definitely. Yeah. For the definitive therapy, we will have to give. We will start with hematopoietic stem cell transplantation, but not actually in pregnancy. And we should give some immunosuppressive therapy also, like anti-thrombocyte globulins and anti-lymphocyte globulins, also cyclosporine. Now a newer drug is coming, which is very much effective for the steroid refractory ITP, which is called as Eltrombopac. And it is also used in severe aplastic anemia where there is a reflection for the immunosuppressive therapy. So that can be kept at hand also.
Yes,
I think, madam, this drug.
Yeah.
This drug is also given. I recently had an experience. Hematologist has started prescribing in addition to thing, I think for ITPs also. No, I think it is used for ITP.
Yes.
When it is not responding to their regular.
And when she is having some bleeding diathesis at that time, if at all she is having a bleeding tendency, yes.
Yes, ma'am.
So this Eltrombopac, it binds to the thrombopoietin receptor. Okay. And these hemopoietic stem cells, now that results into platelet production, overcoming the depletion. Okay. Now this patient was actually prescribed this tablet cyclosporin 150 milligram BD, folic acid, and this newer drug, again the romiplostin. And of course, iron and calcium as a routine, blood products, platelet transfusion, as you have already talked about. So this lady now comes to you as emergency at 37 weeks when you examine. 34 week size pregnancy, breech presentation, fetal heart is good, cervix is 3 to 4 centimeter dilated. Station is -3 high up, and there is a vaginal septum also felt. Investigations, RBC count is quite okay, 2.9, HB 7.8, platelet is 28,000. How do you manage the obstetric part of it?
I have to answer it.
Yes, yes.
Dr. Priya.
Dr. Priya also can take up this. Dr. Priya, yes.
I think since this patient is in active labor, I think she can be even delivered vaginally.
Yeah.
And in this
Yeah, if
case,
you want me to repeat again, it's a 37 weeks breech, 3 centimeter dilated, and breech is higher.
But considering that her platelets are so low,
Yeah,
I would
I'm
definitely give a
just
try.
making her aware because I thought she's not, but I'm giving you the choice whether you want to go ahead with vaginal delivery or you want to go ahead with cesarean section. How do you take this?
I think, madam, we can see her progress and gradually. And if the breech comes down and considering she is dilated, I would prefer to deliver her vaginally.
Agreed.
In case it doesn't, but after again, in this case, we will have to keep blood.
But before that, inform, counseling,
Madam,
yes, Dr. Lakshmi.
I have a difference of opinion here. I
Yes.
think because she's a breech and the station is too high up, even if she's 37 weeks or 34 maybe because of FGR, so maybe give SDP and take her for section could be another option, unless she's progressing very fast. Because the breech is at -3, we are only worried about the
That
platelet.
is what exactly I want to discuss because, see, after all, she has all these problems. She's not in second stage ki breech perineum pe hai to deliver kar lete hai. Breech is very high up. So again, if at all she lands up into some complications, problems with, trapping of the aftercoming head, or maybe distress, and then you have to take her for cesarean section. So you have to face the situation where there is a dilemma, even there is a questioning from the relatives. Best ways to discuss with the patient and relatives, make all the possible arrangements for blood component, platelets, whatever, as you said, single donor platelet concentrate also you can, arrange. And then now you give a informed choice to the patient and relatives. If at all they say, well and good, if at all, we are ready to wait, but madam, if at all any problem, please take her for cesarean section. I think that should be the consent. And then of course, if it is not progressing and you have to take her for cesarean section, that will be timely and appropriate intervention with all informed consent, right? But if at all she doesn't progress to vaginal delivery and she gets stuck up with the breech high up, or maybe even that vaginal septum is going to bleed a lot if at all she lands up into arrest at that point of time. So you have to cut that septum. If it is a very thick septum, again that you have to see that you cut it and clamp it and suture it properly. So everything has to be explained. Then you take a call what you want to do. Okay, so given a choice, what will you prefer, Priya?
So in this case, madam, as you rightly said, we need to counsel the patient. You need to tell the relatives.
No,
we'll give her a progress.
After this, what you want to? Now everything is done. They're ready. They're following you, and they've given everything in writing. Now,
so if she's progressing, then I wouldn't mind yet trying a vaginal delivery. In this case, yes, we will have to keep in mind that septum will need to be excised. Blood and blood products will be required. This patient, we will have to give her blood because even our platelet counts are very, very low. And maybe even we may consider even platelet transfusion if required.
Yes. That has to be arranged. That's what we have said. Okay. So for her, actually, after considering everything, she was given a choice, and on this side, going ahead with vaginal delivery, if at all there is a problem, you may lose the baby also, or severely asphyxiated baby, and she may even have traumatic or difficult vaginal delivery, and she may bleed also. So she has opted for cesarean section, and the problem got solved without any much of intervention. Because as we have already discussed that she may need this excision of the septum as well. Everything we have to weigh the risk and benefit. So she has opted for cesarean section. That is what the end of the story for that case. Now we go to the next case now, Dr. Pranjal Joshi. Do we have Dr. Pranjal here?
Yes, madam.
Yes. So, Dr. Pranjal, this is primary gravida with 7 months amenorrhea. She comes to you with severe body ache, upper abdominal pain, swelling over lower extremities, breathlessness, high colored urine. And when you examine, she's got severe pallor as well as icterus. What is your clinical diagnosis?
Pregnancy with severe anemia, madam.
Yeah, severe anemia, but what kind?
Hemolytic.
Hemolytic, because she's having icterus as well.
Hemolytic
So
anemia.
clinical diagnosis is hemolytic anemia. Okay.
Yes,
What
high
investigations
colored
you would like to do for this patient?
hemogram, complete hemogram, peripheral smear,
Okay.
serum ferritin and all workup, iron workup.
Yeah. For jaundice, you want to do something?
Yes, SGOT, SGP, liver function test.
Yeah, all the liver
And
function,
serum
especially
creatinine because
LDH.
high colored urine. And I will also advise HB electrophoresis.
Right.
Why 5 gram she is having, whether it is sickle cell anemia.
Okay. So you have done all these investigations, and now how will you manage this patient? You find that, she's got SS.
She is having, if she is having sickle cell anemia, I have to give a transfusion. And
Otherwise also her HB is 5 gram%, so you have to give her blood transfusion.
Yes, I have to give transfusion, at least 2 transfusion. And
okay, anybody wants to add anything?
These patients, madam, can I add something? You need to keep them well hydrated. Any dehydration should not occur because the sickling crisis can occur. You need to oxygenate. So even oxygen is very important for these patients, and infection prevention. And what she said, the blood transfusion and blood products need to be kept.
Yeah, that is to prevent sickling crisis. But don't you think she's already in crisis?
So sometimes they may
severe
need
anemia. She's got severe jaundice. Okay, so hemolytic crisis she's in.
Hemolytic crisis. So good hydration is very important because
Yes,
and even
So-
overcrowding and all that can reduce this. So you need to give them an open environment.
Yes, that is a preventive aspect of it. Now that she's into hemolytic crisis or
Will, can I say, ma'am?
Yes, please.
Because this is a hemolytic vaso-occlusive crisis, we'll have to give her heparin to decrease the hypercoagulable state, and of course give dehydration, warmth, oxygenation, maybe antibiotics to prevent infection. Steroids also, a short dose could be given at that time.
Yes. So all these things, as Priya also has rightly said that yes, for preventive aspect, that also continues here because you don't want her to progress further. So definitely all these points have to be covered, and this sickling crisis has to be managed very, very effectively. You have to give her some sort of thromboprophylaxis. Some people give low molecular weight heparin, some people give fundoparinox. I have managed, this is my own case actually, we have managed such cases. So this lady has received fundoparinox, that is the one more type of low molecular anticoagulant. Yeah, so we have to maintain good oxygenation, hydration, blood transfusion, because the more the oxygenation will be more even when the atmospheric and the oxygenation you give, but the hemoglobin has to be good to reach it to the tissue. Avoid crowded places, as you said, high altitudes, and of course you cannot give hydroxyurea during pregnancy. Maintain the folic acid. What are the interventions by Government of India for anemia Mukt Bharat? That's a question for Dr. Bhagyashree Ranjwan.
Prophylactic iron and folic acid supplementation. Then deworming. So tablet albendazole 400 mg is given. Then mandatory provision of iron folic acid fortified food in government funded program, and addressing non-nutritional causes of anemia in endemic pockets with special focus on malaria and hemoglobinopathies.
Right. So this is, and for this, how do they give the iron supplementation, iron folic acid supplementation for how many days?
Iron folic throughout pregnancy and 3 months after delivery or after cesarean section, patient has to continue
That is what
iron
we are following.
tablets.
The government says it's 1,000 day. Okay.
1,000 days.
Okay. Yes, it's 1,000 days schedule, right? Okay.
Okay.
Before we go to the next case, only for a sickle cell crisis, no, for this case, I just want to give one message that, this is a totally preventable condition to be transferred into the next generation, right? Do you all agree? Because once the lady has sickle cell disease or sickle cell trait, for her, she has to face, but she can avoid this coming into her next generation, and that is why not only the preconception but premarital counseling is very, very essential. And those relatives who are having sickle cell trait, at least you make sure that both the partners do not have sickle cell trait, or even the SS pattern is there earlier. Then you have to advise them against pregnancy. Nowadays you have lots and lots of therapy. We will talk about it little later, but you can definitely counsel the couple. Those who are having sickle cell trait, they should not get married. If at all such couple you have in your clinic under your treatment, then of course you have to go ahead with chorion villus sampling right in the early pregnancy, so that you can detect or diagnose the presence of a affected fetus SS pattern. Yes, Dr. Lakshmi, you have some point to say?
No, madam. I think
Yeah,
you've covered everything.
Yeah,
About
thank you
this
so
is
much.
main is the counseling, preconceptual counseling.
Yes.
That is again very important because.
Yes, very good. So I think our expert has not joined, Dr. Anil Sakre. Can you all see him? So I think he was busy in OT. He was busy in OT, but never mind. We go to the fourth case now. Dr. Priya, this is for you. I hope you all are finding it quite interesting, or if at all
Very
anyone
nice.
wants to add anything, please let me know. Okay. So this is a case, Priya, for you. 29-year-old lady, third gravida. She has had last 2 abortions. Now at 28 weeks, she comes to you with ITP, diagnosed ITP, referred to you. So she's on prednisolone, folic acid, iron, calcium. Splenectomy was done for her 1 year back, and cholecystectomy also 2 years back. How do you plan to follow her up? Role of IVIG, platelet transfusion, and delivery plans?
So, yeah, madam.
Yeah.
This patient is a known case of ITP. So these patients, there's a gradual reduction in the platelet count throughout the pregnancy. So they need continuously to be monitored. You need to keep checking the platelet count. So initially once a month, you can monitor, and closer to, they require more follow-ups or more frequent monitoring around 36 weeks, because that's the time when the delivery and all we need to look into. And this patient, so usually the management of ITP, unless the patient, so you need to keep throughout the pregnancy a platelet count of more than at least 30,000. And you do not need active intervention unless the patient has a bleeding or there's a drop in the counts. And the role, so the first line of management, and yeah, in these cases, we will like to do further investigations, as you rightly this, that the CBC has to be done, the reticulocyte count has to be done, the peripheral smear has to be done, the liver function test, the coagulation test need to be done. You need to screen for virology, that is hepatitis B, C, and HIV screening also needs to be done.
Because you cannot jump to the conclusion directly. You have to rule out even the
all these other, because it's a cause, it's a diagnosis by exclusion. Here,
and
this
also
patient,
2 things can simultaneously coexist, right?
yes.
So that is how you have to.
Yes. So you need to rule out the other things, and if required, even the autoimmune screening for APLA and all, or the other levels like vitamin B12 and folic acid can be done if required. So the first line.
Priya, I would interrupt you here only. Now, this is a case where ready-made she's come to you as diagnosed ITP. Suppose you get an ANC who is having very low platelet count, to your surprise. Then how do you differentiate whether it is gestational thrombocytopenia, or it is ITP, or it is thrombocytopenia, which is pathological and carries a very high morbidity, right? So how do you differentiate between the 3?
So in the
Madam, first
ITP, usually there will be a history which is present, or there may be family history also. And in ITP, usually from the beginning, there will be a decrease in the count. But and the counts are much lower than 1 lakh. In comparison, where the gestational thrombocytopenia is there, it usually manifests in the 28 weeks in the second trimester, and the counts are not going to be very low.
Yeah.
And
So
usually,
just to clarify, the ITP where you will be having a very, very low count right from the beginning. And when you get surprised, the patient tells you, Madam, माझे असेच राहतात. Okay, so that is what she tells you. And when the gestational thrombocytopenia, when you examine her, you may have the record previously which was normal, maybe pre-pregnancy or maybe early pregnancy. And now when you do it in the second or third trimester, that keeps on, coming down. Yes.
And madam, one more thing is, we actually, can I add, madam?
Yes, please.
We actually sometimes have to collect it in a citrate bulb because if you're not very sure. And other thing is, we get so many of viral fevers nowadays where maybe she's in that phase where the count has fallen. So maybe serial CBCs would also be helpful.
Right. Right.
Can I complete the management?
Yes. Please go ahead.
So in these cases, prednisolone is the first line of management. 1 milligram per kg is given, and this needs to be given. And usually the steroid takes about 2 weeks to 14 days to start acting. And the other way, what you can do is give the immunoglobulin, which is 1 milligram per kg, 1 gram per kg can be also given. Sometimes a combination of the therapies is also given. And usually splenectomy, so we should not, we should avoid unless there's a severe progression, and if it has to be done, it should be done in the second trimester. And the main risk, there are problems even with the baby because there could be fetal thrombocytopenia in about 10 to 15% with intracranial bleeding. And so post-delivery, it's important for us to even monitor the platelets in the baby for at least a period of 5 days. And send the cord blood, do the monitoring. And these are the most important things. And again, in the delivery time, if there is not, so for the normal delivery, you need about 50,000 as the count. And if required, you need to keep platelet also available because if we don't have in the labor and suddenly the patient comes, please keep the availability of platelets also.
Madam, one thing I would like to add here, generally what we do is whenever we have a patient, maybe who is approaching the time of a delivery, that time injectable is given to raise the platelets for the coverage during delivery, and then they go back to the original. This is what the hematologists many a times advise, so that we don't have any problem when she's in labor or when we're going for a planned sections.
What injectables you?
Injectable prednisolone is only given many times.
That is what we
methyl
are
prednisolone. Yes, methyl
prednisolone.
prednisolone. And I think the drug which
once a
we
day
saw
for 3 consecutive days.
Yes,
that gives you a good window where you can, go
where you can
ahead with
deliver,
your
yes.
procedure and intervention. Yeah, that is how we have been managing. Yes.
And immunoglobulins also for 5 days it's given. 1 gram per day.
Yes.
Per kg.
So we go ahead with the next case now. Okay. I hope I'm not, going hurriedly, but I think it's a good discussion. You all are already contributing to it. So we go ahead with this case now. You have this 4th gravida who has had 3 spontaneous abortion. Now she comes to you with 2 months amenorrhea. And this is actually just a revision for you. Okay. Considering her bad obstetric history, she was investigated. All other tests, including APLA, was negative. For RPL, she was investigated. Previous karyotype of POC was normal. Parental karyotype was normal. She doesn't have GDM or hypothyroidism, and so she was subjected to thrombophilia profile. That she was found to be positive, protein C and S deficiency, and on further inquiry, she gave history of DVT also following her road accident. What is your diagnosis and whether you would go ahead with management? How do you go ahead with management? Naturally, I have already given you a clue. This is a case which is different from the talk, if you remember. This is a case which is not different. This scenario is totally different. You have process, you have hereditary thrombophilia positive, and there is a history of DVT. Now you go ahead with the who is taking this case?
Aparna is not joined.
Okay, so who
He is
is
a case of
remaining? The remaining participant, let me know who else. Somebody we are missing, no, in the panel. Pranjal Joshi has also done.
Rupali is not there, I think.
Rupali is not there. I did see her, no, I think.
She was
Okay.
not there.
Okay. So I think we can start from the beginning.
She is
Bhagyesh.
a case. Ma'am, she is a case of inherited thrombophilia. And she is on inquiry, she gave history of deep venous thrombosis. So we have to start injectable low molecular weight heparin.
Yes, and
She,
aspirin also.
yes, aspirin and heparin both. So aspirin we have to give 150 at bedtime, and heparin, low molecular weight heparin 40 per day.
So how much aspirin, how much, and heparin, how much?
Aspirin 150 mg at bedtime.
Yes.
And heparin 40 international units subcutaneously.
Okay.
Madam, she has to be continued with this prophylaxis throughout
She
the
has to
pregnancy?
continue aspirin till 34 weeks. And
not
heparin.
34 weeks, not 34 weeks. Yeah. See, whatever the thrombophilia prophylaxis is there, no, if she is at a high risk of thrombosis, the thromboprophylaxis, now here she is very high risk. Okay. Deep vein thrombosis is taken as high risk. You score it as 3. Okay. So 3 is very high risk. So you have to start the thromboprophylaxis right during first trimester. Take it throughout the pregnancy and even continue for 10 days postpartum at least. At
Madam,
least
at
10
least
days. If at all she has
around
some
6
more
weeks.
risk factors, yes, then 6 weeks postpartum.
6 weeks, yes.
Okay. So,
but ma'am, one question.
Yes,
before delivery, we have to stop now for 24 to 40.
That is
we are coming
12
to that.
hours.
We are coming. So it's
Prior.
only 24 hours prior. Okay.
That's it, yes.
See, all my slides have all your answers also. What is the recommendation that it has been already covered in the talk, that if at all the patient has RPL and if she is APLA positive, then only give low molecular weight heparin. That is what H3 says. But let me share with you all my own experience. I'm practicing since 32 years now. I have got very high risk patients, and patients who have had 3-4 abortions and they nothing else is positive, and hereditary thrombophilia profile is positive. They are, managed well on the low dose heparin and aspirin combination, and they're having a very good prognosis. So it's not that you should not use. Till now, evidence doesn't support. But from where the evidence will come, it will come from our own data. So if at all of you are using, please do use continue, because see what the patient, it will be between, you have to discuss and take an informed consent, that because you don't have anything else, you have to have this treatment, right? So with informed consent, you take it so that you will be safe on paper. But this is giving you very good result. At some time, earlier also somebody has asked this question, that if everything is negative and still she is having bad obstetric history, then of course you have one more weapon to use, that is low dose aspirin and low molecular weight heparin. If that is giving you positive outcome, why not to use it? Okay, only use it with informed written consent and use it safely. As it is low molecular weight heparin doesn't need much of monitoring. So this is the extra recommendation what I was talking about, that you don't have to use low dose aspirin and heparin for a case of hereditary thrombophilia unless there is in the context of venous thromboembolism. So our patient already has venous thromboembolism. So we come to Dr. Lakshmi. Now, what are the criteria to classify risk for venous thromboembolism and it is? Yes.
Madam, there are some pre-existing risk factors which you have to consider, like maybe previous history of venous thromboembolism, which is not related to a previous only surgery episode. So if that is the case, that the score goes to as high as 4. And the other thing is, if she has some comorbidities like maybe cancer, heart failure, then diabetes and all, they go for score 3. A previous venous thromboembolism, which is really provoked by a previous surgery, the score is 3, and a known high risk case thrombophilia.
Right.
These three. This is for the pre-existing. There are some obstetric risk factors which are present, like she's a case of pre-eclampsia. She's an IVF or ART conceived pregnancy, where all have got risk factor score as 1. Her BMI is more. She is more age more than 35. She's a multipara. She's a smoker or has varicose vein. So these are some. Other risk factors is very interesting is patient who have a cesarean section in labor.
Yeah.
So these factors are very important. Cesarean section in labor, then
Is
elective
scored as
cesarean
2.
section. Yes,
Scored
and
as 2,
PPH.
and elective one is scored as 1.
Yes, and PPH more than 1 liter, preterm delivery less than 37 weeks. All these are obstetric risk factors, and some are transient, like patient getting admitted for hyperemesis, OHSS. So the guidelines say when you have got 4 risk factors, then better start a prophylaxis from the start throughout the pregnancy and for 6 weeks. If the score is score 3 factors, then you have to start it from 28 weeks. But if it is only 2, then only for 10 days. For other 2, you have to continue to 6 weeks.
Yes.
And I was just thinking, madam, when I was going through all this, I got a thought for the thesis for my next student, because we have to assess this factor. They say that you have to actually assess these factors first time when she is coming to you, again reassess if she is getting readmitted, then after she delivers. So this time you can reassess and then continue the prophylaxis. So that is really one thing. Because we are, I think, scared of giving heparin. We give it for 4 days, 5 days. So we should continue for a longer period.
Yes.
That is more important.
That is what I that's the reason I was sharing with you that I have so many cases who I have one case who is 10 spontaneous abortion, educated lady, going all across the district up to Nagpur and Pune, Mumbai, everywhere, and she had 11th pregnancy, delivered a full-term baby with me with low molecular weight heparin and
Yes.
okay, so that is very, very satisfying, and that's the reason I have included these cases here. I hope all of you are finding it interesting. So what are the options for thromboprophylaxis, Sunita?
Ma'am, for thromboprophylaxis, we can opt for low molecular weight heparin or unfractionated heparin. We prefer unfractionated heparin after 36 weeks because action can be easily reversed with protamine sulfate and monitoring is easy with APTT.
Yes.
So both can be
But
given.
do you really think that it is LMH is really, I mean, LMW is really so worrisome? Because
no, ma'am.
Yeah, because that question will be
For
coming to you.
prophylactic dose, it is quite safe. Only if it is
therapeutic
therapeutic dose, then we'll monitor.
Yes. You don't have to even monitor platelet. They are not altered by
Yes.
40 international units. Correct. Very good.
Madam, can I ask you one question? Because you have got a lot of high-risk patient. It is said in the guidelines that when you have a case of previous venous thromboembolism, and all, you have to increase the dose of low molecular to 50 to 75%
That is
above.
what we are talking about, therapeutic and prophylactic. But what we are using 40 international unit is prophylactic. Yes. And
For therapeutic, we'll give twice a day, na?
Yes. Twice a day. So that comes 80 ml. Right. And even that according to weight, that will come to it later on.
1 milligram per kg per day.
Yes.
For low molecular weight heparin.
Just to summarize, low molecular weight heparin, these are the agents of choice for antenatal and postnatal thromboprophylaxis. Doses of low molecular weight heparin, they are based on weight. And of course, for thromboprophylaxis, the booking or most recent weight can be used as guide. And it's not necessary to monitor the platelet count. You can even continue it right up to the delivery, because sometimes it can happen. You have to actually stop it 3 days prior. But if not, maybe if some patients are very high risk, you may have to stop it 3 days prior. Then you have to take them on unfractionated heparin, right? But then even if you land up into any emergency, the patient doesn't bleed much. I have experienced many times, that I tell the next week we will stop your heparin, but then suddenly she comes with leaking. So it doesn't affect the coagulation profile so much and even the platelet count. So you don't have to worry much about. Low molecular weight heparin is very safe even during breastfeeding. So not to worry about it. Okay. What is the difference of unfractionated heparin and low molecular weight heparin? Anybody can take up this. We can go ahead. When do you have to stop the heparin? Yes, Dr. Sunita.
Can you repeat the question? I didn't hear you. It was some network issue.
This is the comparison of low molecular weight heparin and unfractionated heparin. When should we stop? We have said that low molecular weight heparin, you have to stop at least 3 days prior. And unfractionated heparin, you can continue because it has got a very short half-life.
Short half-life.
Yes, yes. So that is what. So, if for some patients, if the low molecular weight warfarin is used, where heparin is not suitable, that is what is the, this is the chart. Warfarin is used where heparin is not. Some patients, they are not, for them heparin is not suitable. So warfarin also can be used during pregnancy, especially women with mechanical heart valves. They are already on warfarin. So you may continue to put them on warfarin. Then women receiving long-term anticoagulation with warfarin, now they can be converted to or taken over to low molecular weight heparin. Again, they can be shifted to, so at 36 weeks, you may have to take them on unfractionated heparin because you feel that, unfractionated heparin has got a short half-life and where the patient has a very high risk of thrombosis. So you don't want to stop the heparin at all. Okay. For low molecular weight heparin, we are saying we have to stop at least 3 days prior. But this is a case where the risk is very high. You don't want to stop. So you can now take her on unfractionated heparin, stop only 12 or 24 hours prior, deliver her or do whatever procedure. Again, you put her onto unfractionated heparin. And then once she settles down, you bring her back to warfarin. That is how it is.
Madam, and one more thing is the concept have changed about warfarin. The patient, like in mechanical valve, they're already on warfarin. So we used to be worried about warfarin embryopathy. But I think as far as the American Heart Association guidelines said, less than 5 milligram is not going to cause embryopathy. So it's better to continue for that anticoagulant. That is what we were talking with cardiologists. They are of the opinion that you can continue warfarin.
Yes.
Mainly for this anticoagulant.
But if at all you have to shift, you can shift
low
around.
molecular, yes. The only advantage of low molecular, it doesn't need any monitoring like what we have to do. Very, very rarely we have to go for any monitoring techniques for that.
Yes, yes, that's the only thing. So other measures apart from low molecular weight heparin.
But we can't hear you, I think.
I think we have lost her somewhere.
Yeah. In some connectivity issue.
I thought I was not able to hear.
Connectivity.
Hello?
Yeah, madam has come, I think.
Yeah. I'm sorry. Actually, I got disconnected. I don't know because of the network issue. I'll just share my, I think last few slides just to conclude. Maybe with this case, we will conclude. Okay. I hope you can see.
Yes, ma'am.
Yes, ma'am. Yes, ma'am. Yeah. Audible.
So I'll just make this full screen. Yeah. I think you can see now. Okay.
Yes.
So this is just the algorithm what we have talked, if you have a score of 4, you have to start the thromboprophylaxis right in the first trimester, continue throughout the pregnancy, just stop 24 hours prior to the delivery or whatever intervention. And again, postpartum, you continue up to 6 weeks. If you have a score of 3, 2 to 3, then that is called as intermediate risk, that you have to start the thromboprophylaxis at 28 weeks and then you can continue throughout the pregnancy and 10 days post delivery or postpartum. If she is at lower risk, that is less than 2, then of course you just start after 28 weeks, continue till delivery, and post delivery postpartum you have to just use other methods along with heparin, as we have already said, only for first 10 days. Okay, low molecular weight heparin. If at all the patient doesn't tolerate heparin or she's not suitable, then of course you have to go for early ambulation and the other devices, what we have said, the intermittent compression devices, graduated compression on the calf pressure of 14 to 15 millimeter of mercury is recommended. That is in pregnancy and puerperio for the women who are at high risk, morbidly obese ladies who have got very severe diabetes, very high cholesterol, and those who are not very well ambulatory. So for these patients you can use this. So this is the algorithm for this. I think we don't have Dr. Rupali, so we can conclude with the panel discussion. I think we have lots of interesting cases still, but I just thank all of you for your excellent inputs, and definitely I would like to utilize this opportunity for making an humble appeal to support me, my candidature as FOXY Vice President. Not only support the candidature, but please do maximize your voting from all your societies to make me win. So with this request, I end my discussion, and
thank you. Thank you, madam. It was very interesting.
Thank you, madam.
We learned so much.
Thank you, madam.
And good luck for you. And we are always there for you, madam.
Thank
we
you.
have been associated since so long. Definitely.
Thank you very much, madam. It
Definitely.
was quite informative.
Thank you, Dr. Oswal. Thank you.
Thank you, madam, for the
madam.
opportunity.
Yeah.
All the very best.
Lakshmi, thank you so much. Over to you,
Thank you.
Dr.
Thank you, madam.
Madan. Yes.
Yes.
Dr. Bhagesh. Yeah.
Thank you, ma'am.
Yeah, it was a wonderful panel discussion as usual by
Lalita Bajaj,
Sneha ma'am.
Namaskar.
Yes, thank you.
Thank you so much for being associated.
Yeah.
Thank you,
Thank you
madam.
all the
Thank you.
panelists and Sneha ma'am. Yes, thank you, AMOGS, and thank you all the chief guests, guest of honor, and all the speakers, all the delegates who have joined, and all the participants of this panel, and all the 3 societies, Aurangabad, Bid societies, and thank you IMA also for participating, associating with AMOGS for this today's event. Thank you once again. Looking forward to further associations in near future.
Yeah, we
And,
missed
humble appeal
Dr.
for Sneha ma'am. Humble appeal for Sneha ma'am to vote her for this upcoming elections.
Vote for me to make me win. That is what now I have to make.
Thank you.
I
Thank
want
you.
to work for all of you. I want to represent all of you. See, all of you are so closely associated with me, and you know what type of personality I am. So I really need your support.
Definitely, ma'am. Definitely. Best wishes.
Yes, ma'am.
Thank you so
All
much.
the best.
Best wishes to you, madam.
Please
Best
allow me
wishes.
to disturb you during the voting period at least once. Okay. Thank you so much.
Okay. Thank you. Thank you.
Bye-bye. And
Thank
thanks
you,
to
ma'am.
Madan and Monica, who know my right and left, who are working very hard for me. So thank you so much, Madan.
Yes, thank you,
Thank
ma'am.
Thank you. Good night. Bye-bye.
Good night.
Good night, ma'am.
Good night.